Good evening. Welcome to the oral cancer screening exam is suspicious. Now what? The numbers for the year 2020. Over 53,000 Americans will be diagnosed with oral or oropharyngeal cancer this year, with over 10,750 deaths, according to the American Cancer Society. Worldwide cases, 450,000 patients, not dollars, patients, most likely underreported according to the World Health Organization because of the incidence of oral cancer in many third world countries or even first world countries that have poor reporting of oral cancer cases. So a lot of people coming down with this. One person every hour of every day will die of oral or oropharyngeal cancer this year in the United States. Where I am right now, it's 7 p.m. I got up at 7 a.m. this morning. So since I got up this morning, 12 people in the United States have died of oral cancer. And frankly, that's unacceptable. And why is it like that? Well, we'll talk about that over the next hour. The 5-year survival rate is 57%. That sounds pretty good. But if you put it another way, the 5-year death rate is 43%. Not so good. And it is not significantly different for the last few decades, according to the Oral Cancer Foundation. And we'll talk more about the Oral Cancer Foundation over the next hour. Well, so let's take a look at 5-year survival rates of different cancers. Oral cancer, 57% 5-year survival rate, as we said. Colon and rectum cancer, 66% better survival rate. Leukemia, 66% better survival rate. Breast cancer, 5-year, 91% survival rate. So all of these relatively common cancers have a much, much higher survival rate than oral cancer. Why is that? Stay tuned. We'll get to that. Deaths in 2020 estimated from the American Cancer Society. Oral cancer, 10,750. Melanoma, 6,850. Cervical cancer, also a cancer that is difficult to diagnose, 4,290. New cases in males for the year 2020 estimated. Oral cancer, 38,380, leukemia, 35,470, pancreas, 30,400. So much higher incidence of oral cancer than leukemia or pancreatic cancer, both of which get a lot more publicity. Incidence in men is more than twice the incidence in women. Why is that? Well, a lot of social reasons. Men usually smoke more than women. Men usually consume more alcohol than women. So those are two of the big risk factors for oral cancer. And we'll talk a little bit more about risk factors in a few minutes. So why is it so lethal? Well, we don't look. That's the biggest reason. We just don't look as a profession. Or we think we look, but we don't look correctly. We don't know exactly what we're looking for or how to look. Or some clinicians are just plain afraid to look. They don't want to face a patient that has the possibility of oral cancer, so they look away and they don't even bother doing a good oral cancer screening. How do you do a good oral cancer screening? Oh, we'll get to that, don't you worry. So only 29% of all oral and oropharyngeal cases are diagnosed at the local stage when the 5-year survival rate is 84%. What does this mean? This means if we can diagnose at the very beginning, if we can diagnose these cases when the cancer is just starting out, before it's too big, before there's any metastasis, the survival rate is 84%. So how do we find it at that stage? That's one of the things we're going to be talking about. So 71% of all cases are discovered too late. That's a terrible indictment of the dental profession in general. We've got to do a better job of discovering oral cancer at an earlier time. So early dysplasia is when we want to start to diagnose it. Moderate dysplasia, it's already growing. Severe dysplasia, not very good. By the time it reaches oral squamous cell carcinoma, we've got a problem on our hands. The dysplasia starts at the basement membrane, and you can't see it in the basement membrane. That's one of the reasons why when we talk about a good oral cancer screening, we're going to talk about bimanual manipulation. We're going to be talking about just a digital exam where you're using your fingers to feel, because you can feel these things before you actually see them. But more important, fluorescent visualization can see it before you can see it. So that's one of the things we're going to talk about. How do you find these things early? Use an adjunctive device, such as a type of fluorescence visualization. So what are the risk factors? Well, you know what they are. Alcohol, certainly. Tobacco, certainly. So alcoholics have a high incidence of oral cancer. Smokers have a high incidence of oral cancer. And if you smoke and use alcohol, there is a 30-fold synergistic increase. And of course, HPV, human papillomavirus, very, very big risk factor these days for oral squamous cell carcinoma, as well as, of course, cervical cancer. So I have two patients, a 75-year-old male non-smoker, social drinker, in a monogamous relationship with his wife of 50 years. And I also have a 35-year-old single stockbroker. I find similar lesions in both of their mouths. Who am I more worried about? By far and away, I'm worried about the 35-year-old single stockbroker. Why? Simple. He's single. The odds are that he has multiple sexual partners. How do I know that? He tells me. I'm like his barber. Way too much information. So I know about his sexual conquests. What's that? Why is that important? Possibility of getting HPV, human papillomavirus. I know he goes to a cigar bar, has a couple of scotches, has a couple of cigars. So he smokes, he drinks, and he has multiple sexual partners, which increases drastically the possibility of him being exposed to human papillomavirus. So I'm much, much more worried about that 35-year-old than I am about that 75-year-old. So don't think that oral cancer is a disease of older people or low-income people. It's a disease of everybody. So Marcia Cross, some of you may remember, she was one of the stars of Desperate Housewives, also Melrose Place, also Quantico. She had anal cancer, has anal cancer, and her husband, oral and oropharyngeal cancer, both of them caused by human papillomavirus. So what do Babe Ruth of the New York Yankees, George Harrison of the Beatles, and Humphrey Bogart have in common? They all died from oral pharyngeal throat cancer. Any sports fans listening? Tony Gwynn, Hall of Fame right fielder for the San Diego Padres, died of oral cancer. He was addicted to snuff, to chewing tobacco. His family sued the chewing tobacco company, stating that they made him an addict, and he could not kick the addiction, and that's why he died. I'm curious to see how far that lawsuit goes. Jim Kelly, we'll talk about in more detail in a minute. He's enshrined in Canton, Ohio, in the Professional Football Hall of Fame. Quarterback for the Buffalo Bills for many years, still lives in the Metro Buffalo area. Oral cancer. Curt Flood, if you're a baseball historian, you know the name Curt Flood. In the olden days, before free agency, baseball players were the property of their teams. The teams could do whatever they wanted with their players. Well, Curt Flood was traded. I want to say that it was from the Cardinals to the Phillies. I'm not 100% sure. He didn't want to be traded. He didn't like the idea of being traded. He sued Major League Baseball. The lawsuit went all the way up to the Supreme Court of the United States. And that is how baseball free agency started, thanks to Curt Flood. He survived oral cancer. Brett Butler, pretty good outfielder, had a nice long career starting with the Atlanta Braves, then finished out with the Mets and the Dodgers, survived oral cancer. Curt Schilling, famous pitcher for the Boston Red Sox and Arizona Diamondbacks, won a World Series with each of them, survived oral cancer. Let's talk a little bit more about Jim Kelly, Hall of Fame quarterback, Buffalo Bills. He first revealed in June 2013 that he had squamous cell carcinoma of the upper jawbone. He had surgery to remove the tumors, but then announced in March 2014 the cancer had returned. Kelly then underwent weeks of chemo and radiation treatment before the doctors declared him cancer-free that September. His second battle with cancer took a serious toll on him as he underwent 12 biopsies in addition to the chemo that eventually led to a MRSA infection in his facial bones. He spent more than 3 years in remission till the oral cancer returned in March 2018. This is stuff people just don't understand about oral cancer, how disfiguring and life-altering it can be. March 2018, doctors are declaring Jim Kelly's surgery a success. The Hall of Fame Buffalo Bills quarterback underwent a 12-hour procedure on Wednesday to remove oral cancer and reconstruct Kelly's upper jaw. The physician, the head and neck surgeon, said, "We successfully removed Mr. Kelly's cancer from his upper jaw and lymph nodes from his neck," said Dr. Mark Erkin, head and neck surgeon at Mount Sinai West. "We then reconstructed his upper jaw. Mr. Kelly is resting post-operatively." Jill Kelly, his wife, said in a statement her husband's recovery would be extensive. Jim is expected to remain in the hospital for a few weeks. So there was recently an interview with Jim Kelly in the AGD Impact, the little journal from the Academy of General Dentistry. So I took this little piece from the interview with Jim Kelly just a couple of days ago. And he's talking about the oral cancer. Came back a little over a year and a half ago. He said, "I was having issues on the other side of my mouth, and my dentist said I needed to have a biopsy. So I did, and it had come back. I had a couple of options. I could have a surgery where part of my skull was removed. Doesn't that sound like fun? Or I could have part of my left fibula removed, broken into 4 places, and then used to reconstruct my upper jaw. Then the doctors would take blood vessels from my arm and my leg and use those to rebuild my whole upper jaw. So I chose that option. I told people I know I've put my foot in my mouth a couple of times, but I've never had my fibula in it." Pretty brave, considering the 12-hour surgery and what he went through just as a result of something that quite possibly could have been caught at an early stage. Still, Kelly had to undergo another procedure in November 2018, and one doctor hoped that would be his last. With the MRI results coming back clean, that appears to be the case, although there's always a chance for the cancer to return later on in life. Horrible story, just horrible. So entertainment figures, Bogey, Humphrey Bogart Jr., when he died, he weighed 84 pounds. I mean, he wasn't a big guy. He was a rather short-statured gentleman, but 84 pounds. Sammy Davis Jr., part of the Rat Pack, very famous Las Vegas entertainers, was Sammy Davis Jr., Dean Martin, Frank Sinatra, Peter Lawford. Sammy Davis Jr., famous singer-dancer, developed oral pharyngeal cancer, went to his doctor. His doctor said, "I can save you, but you'll never sing again." He said, "I'd rather die," and he did. Bruce Paltrow, father of Gwyneth Paltrow, famous actress, died of oral squamous cell carcinoma. Jack Klugman from The Odd Couple, Quincy, Twilight Zone, whole bunch of other TV shows, died of oral pharyngeal cancer. And Roger Ebert, the film critic from Chicago, had a TV show that was a review of different films. Two on the Aisle, Roger Ebert. And here's Roger after he had a total mandibulectomy. And how did he communicate for the last couple of years of his life? Same way Stephen Hawking did, with a computer synthesized voice. And he typed out what he wanted to say on the computer. Total mandibulectomy. How horrible is that? Sigmund Freud, you always see pictures of Dr. Freud with a cigar in his mouth. Well, he died of oral cancer. President Grant is the only US president who died of cancer. And President Grover Cleveland, survived verrucous carcinoma of the hard palate. The good news is that general practitioners perform 60% of all periosurgeries, 48% of all bony surgical extractions, 40% of all apicos and root amps. Those are all much, much more difficult than biopsies, and I'm going to show you. A good biopsy with good technique, 2-minute procedure. That's it. The bad news, general practitioners perform only 17% of all biopsies. Why make the oral surgeons rich? Do it yourself. It's a high-ticket item. It's a simple procedure to do. Schaefer, who wrote the standard textbook when I was in dental school, said the advantages of a biopsy so far outweigh its disadvantages or potential dangers that biopsy is seldom contraindicated, which means, when in doubt, cut it out. If you don't detect it early, the average malpractice award against dentists for missing the diagnosis of oropharyngeal cancer was over $1 million, and most dentists usually carry just 1 million, 3 million. So you may be underinsured. How do we do a better job of early detection? There's a bunch of devices out there. Oral ID is one, Velscope is another, Identify 3000 is another, Gockles is another, and there are more on the way. For those of you that are unfamiliar with Gockles, it stands for Glasses for Oral Cancer Curing Light Exposed Screening. It's a special pair of glasses that you use with a curing light, and the glasses filter out some of the wavelengths, and it enables you to see oral cancers sooner than if you didn't have this fluorescent visualization type device. So once again, it enables us to see it at the early dysplasia period before it gets worse. That's the critical point. That's what we need to do. We need to get it at the early dysplasia period, not further than that. So how does fluorescence visualization work? Tissue fluorescence. Different tissues fluoresce at different rates depending on their biological activity. Cancerous tissue is much more mitotically active than normal tissue, which accounts for a different fluorescence rate. So, the light that you're going to shine in the patient's mouth causes tissues to fluoresce. The color is characteristic of the combination of the tissue structure and the fluorophores. That's the material in the tissue that absorbs or reflects the energy. So, if you're looking at an area that is not more mitotically active, potentially carcinogenic, it will look one way. It will look apple green, like a Granny Smith apple. Abnormal tissue fluorescence, there's something that's causing that tissue to absorb and reflect light energy differently. So this is going to be fluorescence visualization positive. This is something that means we've got to investigate this. We've got to look at this further. Doesn't mean it's cancer. It means it's something different from the surrounding tissue. That's critically important. It doesn't mean it's cancer. It means it's different than the surrounding tissue. So fluorescence visualization positive here on that top right. The top left is just normal magnification. A Visalite exam with toluidine blue doesn't show the extent of this lesion that shows up with fluorescence visualization. Visalite missed this lesion completely. Severely dysplastic tissue. You think this is a little fibroma, you see this and you're ready to remove this, it's just a little fibroma? Well, let's subject it to fluorescent visualization. Clinically, it looks like a fibroma. Fluorescence visualization, there's a region of carcinoma in situ clearly visible with the fluorescent visualization. So this is the way an oral surgeon would use it, or somebody that performs biopsies like myself would use it. I'm a general practitioner, but I do plenty of biopsies on a yearly basis. So there's a lesion on the lateral border of the tongue. Critically important to know, the lateral border of the tongue is one of the most common areas in the mouth for oral squamous cell carcinoma. So figure 1 is noting that there's a lesion there. Figure 2, the surgeon delineated with a marking pen where he's going to make his biopsy. And then figure 3, he uses a fluorescent visualization device, and he sees the extent of the lesion is far, far bigger than what he had anticipated. So now he's going to have to change his margins, which you see in figure number 4. So if this surgeon didn't use the fluorescent visualization, he would have done an incisional biopsy and would have had to have gone back in for a second procedure. But because he had the fluorescence visualization device, he was able to do a total excisional biopsy of this lesion, save the patient another surgical procedure. Take a look at this. Normal visualization with loops and a headlamp. Palette looks just fine. Don't see anything wrong with it. Looks good. Let's subject this to some fluorescent visualization. And what do we have? We have an area that is lighting up. And let's biopsy it and see what it comes out to be. Moderate dysplasia. Do you see it under normal magnification and lighting? Absolutely not. Here you can see this under normal lighting and normal magnification, maybe a little laryngitis, pharyngitis, a little inflammation, a little bit of redness. So let's subject this to some fluorescent visualization, like the goggles. And we got a couple of areas lighting up very, very differently from the surrounding tissue. This was dysplastic. This area here on the left that you really can't see, take a look on the right, this patient will probably need a hemimaxillectomy, invasive squamous cell carcinoma. Not only a hemimaxillectomy, but an obturator. Not a lot of fun. All right, you're interested, but you got a closet full of can't miss gadgets. How do you make money on this? Well, there's an ADA code for this. I say new ADA code, but it's been around for a bunch of years. D0431. I hope you all know this. If you don't, you ought to write this down. D0431. It's been around for a bunch of years. Big deal. There's an ADA code for it. There's an ADA code for lots of things. Doesn't mean I'm going to get paid for it. Well, let's see my return on investment figures. Let's say you do 1,000 patients a year. How do we get to 1,000 patients a year? Is that a lot? We'll discuss that in a minute. Let's say you charge the patient 25 bucks, and if you use something like a goggles, there's no disposable cost per patient. So you've made $25,000. Let's say the cost of the unit is $2,000. Your 1-year return on investment is 23,000 bucks. Your 2-year return on investment is 23 plus 25, giving you 48,000 bucks. I don't know anybody that charges 25 bucks. If you charge 50 bucks, your 1-year return on investment is $48,000. Your 2-year return on investment is $98,000. If you charge 75 bucks for this, your 1-year return on investment is $73,000. Your 2-year return on investment is over $148,000. So this is not only performing a critically important service, it is also generating a great deal of income, assuming you do 1,000 a year. How do you get to 1,000 a year? Well, let's see. If you work a 4-day week, 6 patients a day have a fluorescent visualization exam. That's 24 patients a week. That's 96 patients a month. If you work only 10 months a year, take 2 full months of vacation a year, and I don't know anybody that does that, that's 960 exams. So can you get to 1,000 a year? Absolutely. But you're still not sure? Well, then I guess we'll have to talk about how to market this to your patients, which we'll do in a couple of minutes. So my experience with code D0431 in New York City. Some Guardian life insurance policies, not all, but some, pay up to $150 on patients 40 years of age and over every 24 months for a D0431. Not all Guardian policies, but some of them. Some MetLife policies pay up to $150 every 24 months, patients 40 years of age and over, for something you should be doing as part of your exam. Same thing with Aetna, same thing with Cigna. Unfortunately, I have seen a grand total of 0 Delta dental plans that pay for this, but a bunch of other insurance plans do pay for this. So make sure you write that down, D0431. So when you perform the biopsy, and you should, we'll talk about that in a few minutes, you get paid a very nice fee for the biopsy procedure as well. A little bit more on this a little bit later on. So let's take a look at Gordon Christensen's clinical report, volume 5, issue 7, July 2012. What did Gordon say? Fluorescence is a viable adjunct to, what's that word? Mandatory oral cancer screening, because it reveals abnormal cells before they may be noticed visually. That's what I've been talking about. With these devices, you can see the lesion before you would have been able to see it without these devices. What does Gordon continue to say? It promotes thorough exam. I'll talk about that in a minute. And it's faster and easier to use than oral dyes or brush biopsies. Cancer screening must be a routine part of oral exams, and clinicians should inform their patients of this valuable service. So you may hear some people poo-poo it. You may hear some people say, oh, these things are just glorified flashlights. They don't work. They don't do anything. I'll tell you why they're wrong. Number one, the literature says they work, and we'll discuss that in just a minute. But even, let's play devil's advocate, even if they don't really work, you know why it's worth it? You know why it'll find something? What's that first sentence say? It promotes thorough examination. You give this to your hygienist. Your hygienist is going to spend another 60 to 90 seconds looking for something. And it's that extra time spent looking that will find something. So there's no reason not to do this. But what does the literature say? Oh, the literature says these things work. How do we market the oral cancer screening, fluorescent visualization? Simple. Let Michael Douglas help you. This was the headline from the New York Post back, I believe, in 2012, when Michael Douglas admitted he was a sex addict and he had unprotected oral sex with a high-priced Manhattan hooker who had HPV in her genital tract, and it was transmitted to his mouth, and he ended up with oral pharyngeal cancer. True story. You can look it up. So how is Michael Douglas going to help you market it? Simple.
In a world where cancer is almost a daily part of the news, one cancer isn't heard about enough. Oral cancers are increasing in the U.S., and as in my own case, most people know little about them. Like many, I thought that this was a cancer that impacted much older people who had used tobacco most of their lives. While that's still a problem, the fastest growing segment of the people developing oral cancers are young non-smokers. A very common virus, one responsible for the vast majority of cervical cancers, is now identified as a cause of this rapid rise in oral cancers. Thankfully, in a fast, inexpensive, and painless visual and tactile screening, a medical or dental professional can often identify early-stage disease. So please, the next time you visit your dentist or your medical doctor, ask for this simple screening. Finding oral cancer in its earliest stages may save your life.
How powerful is that? You think that'll help you market this? Absolutely. I have that running in my office, in my hygiene rooms, on iPads constantly. When patients come in for their cleanings, they cannot have a cleaning without sitting through listening to Michael Douglas. So We have this from the Oral Cancer Foundation, which is a wonderful organization. Please write it down. You'll Google the Oral Cancer Foundation. You'll get all sorts of great information about oral cancer screening, what to do, how to do it, and all of that stuff. And of course, you can download this and you can put it in your waiting room, your hygiene rooms, wherever you want, and have people talk about oral cancer after seeing this little Michael Douglas clip. You need some verbal skills also. You talk to your patients, talk to your female patients. You know, Mrs. Jones, I know you go for your mammograms every year, your sonograms every year. I know you see your OBGYN to have pap smears and they check for HPV, human papillomavirus, to make sure there's no cervical cancer. Well, I've got this device, and this device is nothing more than a screening tool, but it's a helpful screening tool. It can help me find oral cancers before I could notice them otherwise. Talk to your male and female patients. I know you go for your colonoscopy every 5 years, or you have your occult blood samples taken. Well, this is a procedure, this is a device that can help me find irregularities, possible cancers, before they can be seen regularly. Talk to your men about PSA, prostate-specific antigen. Talk to your smokers about helical CTs, which are used to diagnose lung cancer at an early stage. Have the Journal of the American Association article, not the ADA journal, the American Medical Association article. From January 2016, fluorescence visualization guided surgery for early stage oral cancer. What does it say? Conclusion: the use of fluorescence visualization significantly reduced the rate of local recurrence in oral cancer, so that people that use this, that are having biopsies, the excisional biopsies were better. There was no recurrence as a result. So we've got the AMA saying this thing actually works. The Oral Cancer Foundation. Now, April is Oral Cancer Awareness Month. Obviously, it's the end of the month now, and it won't help you for this month, but prepare for next year. The Oral Cancer Foundation can help you with marketing your exams. You can be put on a list that they have, and they will send patients to your office for a complimentary oral cancer screening. It's a great way to get new patients. My dentist doesn't do that. Where do you practice? Suburban or rural practice? I bet there are local newspapers that would love an article from the local dentist about oral cancer screening. Use some of the statistics that I just gave you to start this webinar with. You have an urban practice, as I do. There are plenty of local neighborhood newspapers and penny savers that would love to see a little article about oral cancer screening. How about when the local church or Boy Scout troop or Kiwanis Club or synagogue or high school marching band or whatever is doing something to raise money? You volunteer to do oral cancer screenings for free with your high-tech device. It's a great way to get new patients. And what do I always hear? Gee, my dentist doesn't do that. Great way to get new patients. Now, this is really important. Really critically important. People always ask about false positives and false negatives. What's the deal with this? The rate of false positives and false negatives with this technology is 0. Huh? Really? Is that possible? Yeah, it's possible. You're missing the point. You're confusing a clinical exam with a diagnostic procedure. This is a clinical examination. This is not a diagnostic procedure. Clinical exams don't have false positives and false negatives. Only diagnostic procedures do. All these devices are part of your clinical oral examination. That's it. So these tools are adjunctive tools for your clinical oral examination, just like a mirror, just like a piece of gauze, just like an Explorer, just like a PerioProbe. They help you with the exam. Only a diagnostic procedure can give false positives and false negatives. And we're not doing any diagnosis with this. We're doing a screening with this. Important. Does fluorescent visualization detect cancer? No, it doesn't. It detects abnormal tissue. You then follow up your clinical oral exam, fluorescent visualization adjunct, with a 2-week recall to reevaluate, see if it's there or if it went away, and then biopsy or referral. What else could fluoresce differently? Trauma like a cheek bite, like a lip bite, some medication side effects, allergic responses, thermal damage like a pizza burn, fungal, viral, bacterial infections, autoimmune disorders, systemic conditions with oral manifestations. So there's lots of things that could cause the oral cavity to fluoresce differently. Doesn't mean it's cancer. So these things do not diagnose anything. They're used to screen people for the possibility of abnormal tissue. Think of what's going on these days with COVID-19. People are having their temperatures taken with a thermometer that's flashed onto their forehead. Is that thermometer diagnosing COVID-19? No, of course not. What's the thermometer doing? It's a screening tool. If you've got a fever, well, let's look a little bit further. What's this fluorescence visualization? It's a screening tool, not a diagnostic procedure. So let's look a little further. So remember, these things help you perform the exam. They don't give you a diagnosis. That's what a biopsy is for. The biopsy is the gold standard for a diagnosis. Sorry. Once again, verbal skills are important. So, Mr. Jones, the oral cancer screening fluorescence visualization found something that I believe merits further attention. It could be nothing whatsoever, or it could be a warning sign that we should investigate further. More than 90% of what GPs like me find is benign, so it's really nothing to worry about, but I think we need to investigate it just to make sure, just for peace of mind. So let's get you back into the office in 2 weeks and see what's going on. Make certain the patient keeps that 2-week follow-up appointment. Write it down in the book. If he no-shows, if he cancels, make certain he is called and make certain he gets back in. You don't want him to fall through the cracks. It's still there 2 weeks later. What do? You then walk the patient to the front desk. You call the oral and maxillofacial surgeon, and don't let the patient leave the office until the appointment is made with the oral surgeon. And follow up with the patient that they actually kept the appointment, and follow up with the oral surgeon as well that the patient came for the appointment. People tend to put this stuff in the back of their head, or they put their heads in the sand and they deny that they have anything wrong with them. It's your obligation to make certain they get this taken care of. Or, even better, do the biopsy yourself. What are you going to look for? Hang on, think a slide didn't drop. Well, you're going to look for asymmetry. Half of the mold doesn't look like the other half when you do the face. B for border, irregular, blends in. C, color, not uniform throughout. This is the ABCDE of looking for skin cancers. ABCDE from the American Cancer Society. Asymmetry, half the mold doesn't look like the other. B for border, the borders are irregular, blends in with the surrounding tissue. C for color, it's not uniform throughout. D for diameter, the diameter of the lesion is over 6 millimeters, the size of a pencil eraser. E for evolution, did it change in size or shape or color recently? ABCDE, important to know. Look for differences in color with the surrounding tissue, contour of the tissue, consistency of the tissue, change in function of the tissue. What do I need to do this? A piece of gauze and a mouth mirror. That's it. Highly suggested a fluorescence visualization device. All right, let's start the exam. Extraoral, look for symmetry. Anything asymmetric needs to be investigated. So the best way to check for asymmetry, palpate bilaterally. Both sides should feel exactly the same. If not, investigate further. Check the submandibular lymph nodes bilaterally. Feel for asymmetry. Check the submandibular nodes. Feel the upper and lower lips. Feel and look for induration, something hard. Everything in the mouth should be nice and soft. If you're feeling something hard, there's something wrong. Look for indurations. Look for ulcerations. Bimanual palpation. You feel any ulcerations? Do you see any ulcerations? Do you feel any indurated areas? Place the mirror on the tongue and look all around. And then have the patient say, ah. Push down on the tongue with the mirror. Have the patient say, ah. Visualize the uvula and the tonsils. Let's go back one slide. You don't really see the uvula or the tonsils there. Now we do. Push down with the mirror. You can see the uvula. You can see the tonsils. Even better idea, splurge for $10 and buy a laryngeal mirror from your dental supply company. It's nothing more than a regular mirror with an extra long handle. And here it is. Just a plain old dental mirror with a really, really, really long handle. Patients won't gag as long as you don't touch the palate. Hover between the palate and the tongue and visualize the root of the tongue. When I was a resident 100 years ago, I was given a patient to work on that had oral squamous cell carcinoma. I looked all over his mouth. I couldn't find the lesion. This was before his procedure. I couldn't find anything. Had no idea where the lesion was. Called over the oral maxillofacial surgeon. He took the gentleman's tongue, wrapped it in a piece of gauze, pulled the tongue out all the way down, took a pharyngeal mirror, and at the root of the tongue was a big exophytic growth that looked like a piece of cauliflower on the guy's tongue. That was the lesion. So a laryngeal mirror can be really, really helpful in diagnosing in the back of the mouth where you can't usually see. Wrap a piece of gauze around the tongue, pull it out all the way, look at the lateral borders of the tongue, palpate it. Is it ulcerated? Is it indurated? Look at the other side of the tongue, palpate. Is it ulcerated? Is it indurated? Palpate the dorsum of the tongue, ulcerated, indurated. Why so much time spent on the tongue? Well, I said earlier, it's the #1 site of oral and oropharyngeal carcinoma. #1. Have the patient lift up the tongue to the roof of the mouth. Makes it easier to examine the floor of the mouth. Bimanual palpation of the floor of the mouth. Is it indurated? Is it ulcerated? You see one finger is in the mouth and the other hand is supporting the mandible, and you can feel what's going on. Now let's put this together and see what it looks like.
This video contains the latest recommendations from the 2017 ADA Clinical Practice Guideline on the evaluation of oral mucosal abnormalities. This video offers step-by-step instructions for evaluating adult patients for potentially malignant disorders, or PMDs, and oral cancer during a routine dental exam in your clinic. First, begin the exam by asking your patient if any new dental issues have emerged since their last visit or appointment. During the medical history recollection, pay attention to risk factors such as being male, older, smoking, and alcohol consumption. With the patient's response in mind, next perform a conventional visual and tactile intraoral and extraoral exam. Throughout the exam, use inspection and palpation to look for any changes in color, contour, consistency, and function. Begin the extraoral exam by examining the head and face with both the front and back, taking note of any asymmetries and the presence of pigmented lesions. For such lesions, use the American Cancer Society's ABCDE rule to assess for melanoma risk. Look for asymmetry, border irregularity, color changes, diameter greater than 6 millimeters, and evolution of the lesion over time. Next, observe and palpate the neck on both sides. If lymph nodes are identified, pay attention to the size, consistency, whether they are painful, and whether they freely move or are fixed in place. When evaluating the lips, note any change in the vermilion border, mucosa, and commissures, as well as the lip's color, contour, consistency, and function. Look for indurations and ulceration. Ask your patient to open their mouth and begin the intraoral exam by inspecting the cheeks. Retract the tissue with your thumbs and gently pinch the cheek between your fingers, looking for hidden masses. Use a mirror to examine the alveolar processes and gingiva. Look for changes in color, consistency, or a tooth with bone loss out of proportion with the rest of the arch. Pay special attention to the presence of a lesion with a history of poor healing. Carefully inspect and palpate the hard and soft palate, looking for abnormalities. While depressing the tongue with the mirror, ask the patient to say ah to have better access to the uvula and tonsillar pilars. Using gauze, move the tongue to the left and to the right to examine the entire dorsal tongue. Pay attention to the lateral and ventral tongue as well. Complete this assessment palpating the tongue and nearby salivary glands. This aspect of the exam is important as nearly half of all potentially malignant lesions are usually found in this area. Ask the patient to touch their top front teeth with the tip of their tongue so that the floor of the mouth can be inspected and palpated. Use 2 hands when palpating this area. After the exam, clinicians should consider 2 potential clinical scenarios.
The rest of the ADA video we don't have to go over in detail. I want to make sure we cover everything we're supposed to cover. So, oh my goodness, I found something. What do? I don't want to get involved with biopsies. I could be held liable if I do it wrong or miss something. Nope, not true. There are 4 possible outcomes to a biopsy. It's benign and you got it all. Well, congratulations. Are you done? Absolutely not. What's the next step? Recall the patient periodically to make sure it does not recur. Number 2, it's benign and you didn't get it all. What's the next step? Recall the patient periodically to make sure it doesn't grow. It's malignant and you got it all. Well, congratulations. What's the next step? Send the patient to a head and neck surgeon for follow-up even though your borders were fine. It's malignant and you didn't get it all. What's the next step? Send the patient to the head and neck surgeon for further treatment. So no matter what, there's nothing for you to worry about. There's nothing to be afraid of. So when do I biopsy? As soon as I see something? No. It depends on what you think it is. An irritation fibroma on a tongue ain't going away by itself. So there's the irritation fibroma on the tongue. That's not going to resolve by itself usually. So we've got the irritation fibroma. The patient's got a calculus bridge. What else do you see? Take a good close look. Yeah, there's a hemangioma. We can take care of that as well. So we tried scaling and root planing. We tried Paradex. We tried a whole bunch of things. Nothing helps. What do? Oh, and by the way, the patient's pregnant. What do? Get medical clearance from the patient's OB, 2nd trimester, perfectly easy to do. Take a photo and watch it until 2nd trimester. Anything special about taking a photo? Of course, absolutely. This is how you take a photo, with a perio probe against the lesion. Because today you could be taking the photo when you're standing right up against the patient. Next week, you could be taking the photo when you're standing a couple of inches further away. It's going to look like it's smaller. How do you know? You have that perio probe in the photo, so you can see the exact size of that lesion. No matter where you're standing, right in the patient's lap or 6 feet away from the patient, doesn't matter. You've got that perio probe to show everybody and yourself the size, the extent of the lesion. When to refer, when to biopsy? If there's no response to conservative treatment, after an appropriate course of antibiotics or anti-inflammatories, after removing the local irritant, maybe there's a sharp cusp tip causing an irritation fibroma. So this is the tree that I use. Observe the lesion for 10 to 14 days. If the lesion resolves, you recall when appropriate. If the lesion is still present, biopsy or refer. Well, if the patient's healthy and the lesion appears benign, you biopsy and follow up. If the patient is medically compromised or you use the mnemonic FIG rub, you may want to refer. What's fig rub? We'll get to it in a minute. You may want to refer to a surgeon, get the pathology report, and follow up with the surgeon. What's fig rub? Could it be malignant? Fig rub. Fixed. The lesion is fixed to the underlying tissue. I, the lesion is indurated. It's hard to the touch. G, growth. The lesion has grown rapidly. R, red. The lesion is totally red or red and white. U, ulcerated. The surface is ulcerated. B, bleeds easily upon touch. But you got to use these with some common sense. When to refer? When fig rub turns out badly, use it with some common sense. So this is fixed. This is indurated. This is ulcerated. So it's got three characteristics. Uh-oh. Probably malignant, right? No, it's a maxillary torus with a pizza burn. So use it with some common sense. This grows quickly, bleeds easily, only has two characteristics. Yeah, but this is malignant. It's Kaposi's sarcoma. It's an AIDS patient with KS. So you've got to use fig rub with a little bit of common sense. Probably benign if it's painful. Painful usually means it's inflammatory, not malignant. Bilateral usually means it's anatomic, not pathologic. If there's fever, usually viral or bacterial. If there's multiple lesions, usually viral. Clues that suggest malignancy: sudden weight loss, swollen regional lymph nodes, poorly demarcated margins. These are reasons to refer. When else to refer? You can't visualize the entire lesion. It goes beyond the tuberosity. Or it's between the lower first and second premolars near the mental nerve foramen. Those are areas I'd feel not so confident biopsying. Or it's a vascular lesion. You're afraid of not being able to obtain hemostasis. How about vascularity here? Well, you're not too far away from the posterior superior alveolar blood vessels, so that's something I'd stay away from. Do you know what's normal and what's abnormal? Biopsy this, yes or no? That's geographic tongue. Just observe. Take photos. Yes or no? That's Wickham striations. That's lichen planus. A lot of yellow dots, well, that's Fordyce granules. Perfectly normal. What do we have here? A big, white, swollen area? That's just a prominent linea alba. How about the patient's health? If the patient's immunocompromised, I'll refer because they're not going to heal easily. Poorly controlled diabetic, I'll refer. They're not going to heal easily. Heavy smoker, I'll refer. Drugs like Coumadin, I'll refer. I don't want to have a problem getting hemostasis. History of atypical pap smears, well, maybe there's HPV there. That could be malignant. I would refer. You've evaluated the patient, evaluate the lesion, go for it. All right, I'm in. I don't want to spend any more money on equipment or have to buy biopsy kits. You don't have to spend a penny. Everything you need is already in your office. Tray setup. Biopsy jar, we'll talk about that in a minute. 2x2 gauze, cotton rolls, suture material, your choice. Mouth mirror, tissue pickups, college pliers, anything you want. Needle holder, scissors, surgical suction tip, 15 blade with a handle. This is what you get from the lab. You get the biopsy jar, you get a plastic specimen bag, and you get a little paper where you fill out all the patient's information. Biopsy lab sends that to you immediately. Do you bill dental or medical? However you want. There are plenty of references to change dental to medical codes. My experience, I usually don't get paid by dental because I'm not a participating provider with the medical insurance, and not all dental insurances will pay a general practitioner for certain types of biopsies. So best thing to do, call the insurance company before you do it. Make sure it's a covered expense if you're dealing with insurance. You can't submit your bill for biopsy services until you've received the pathology report. Pathology report gives you the ICD number for medical building and the size of the specimen for dental billing. Different size specimens, different ADA codes. So this is what I get as a report. It gives you the size of the lesion and it gives you the ICD code. This is from the ADA book of codes. So you see there are different size lesions, different ADA codes to use. Neurofibromas, acidic cell carcinomas, fibromas. I've done a whole bunch of things. use only oral pathologists, my opinion. The largest oral pathology lab in the United States is Oral Pathology Lab Incorporated. I have nothing to do with them financially. They're just the largest lab in the US, and I think they do a great job. Now, for a full list of hands-on biopsy courses where we actually teach you and show you how to do this on animal jaws, you can visit Full Spectrum Seminars and click on seminar registration. I'll be doing one September 1st at the Greater Long Island Dental Meeting in the Metro New York region. I'll be doing one September 11th in Mount Laurel, New Jersey, part of the New Jersey Health Professionals Development Institute. This is a little textbook on laser dentistry. I do my biopsies with a laser, but we teach how to do it with a laser, with a blade, with an electrosurge, any way you want to do it. And if you have any questions, need some more information, here's my contact info. And here's my email address. I use a laser. My name is Bob, and I'm a DDS. So it is laserbobdds@gmail. Full Spectrum Seminars is where you can find out more information about some of my courses, which are obviously on hold because of the COVID these days. But we're going to have courses up and running as soon as we can. So thank you very much, and I am ready for questions. Okay, as a dental hygienist, I haven't received extensive training to be able to differentiate between oral lesions. And most of the time the dentist says, not so sure, you have no power to defer. What would you recommend we do when we feel our dentists dismiss too easily these kind of patients? That's a difficult question because it's something you need to discuss with the dentist. Maybe the dentist should be trained on how to use some of this fluorescence visualization devices. Maybe just have a sit-down talk with him that you've taken extra courses in oral pathology and you're a little worried and you'd like to suggest to him to refer more. It's very tricky. I'm sorry I don't have a better answer than that. Sorry. What makes you realize you should make a fluorescent light case in cases where the tissue looks normal? The reason I use the fluorescent visualization is, number one, Gordon Christensen says to use it, and I do anything Gordon tells me to do. Number two, the literature says it works. That's good. Number three, the point is to see these things before you can see them without normal lighting. So that's why I use it. I can see things with the fluorescence visualization that I would not see otherwise. That's important. Can we charge for every recall? Well, if you're a general practitioner or any type of dentist and you don't do insurance, you can charge anytime you want. If you are an insurance-based practice, as I am, usually the insurance companies pay for one exam every 24 months. So that's what I do. I do these exams every 24 months. Initial patient, it's part of my D0150, new patient exam. Otherwise, I do it every 24 months and I get paid from the insurance company for it every 24 months. If you want to do it sooner, it's got to be out of the patient's pocket. What's the percentage of false positive cases with the goggles? Remember that goggles is not a diagnostic test. It's a screening device. Just like a thermometer is a screening device to screen for COVID. It doesn't tell you you have COVID. It tells you there's something going on with the patient that you need to investigate further. So don't think about false positives, false negatives. It gives you an idea that there's something there that needs to be checked, needs to be evaluated to go on further. Can I repeat the code? D0140. No, D0410. Yeah, D0410. If that's not right, just email me, but I'm pretty certain that's it, D0410. I love Michael Douglas. I would absolutely listen to him. I'd rather listen to his wife, Catherine Zeta-Jones, but That's a little sexist, but have you heard of the Velscope technology that's used to detect oral cancer? How effective do you think it is? All of these things work quite well. Nothing wrong with the Velscope. There's a lot of technologies that you can use. Velscope is one, Goggles is one. There's a whole bunch of things. Can you refer to an oral surgeon after an abnormal exam? Absolutely. If you do, I would make certain to take photos beforehand, send the photos to the oral surgeon so he knows what you're talking about. Always take photos, always send photos. Do I recommend fluorescent screening on adults over 18 or 35 or older? The insurance companies pay 40 years of old or older. I do it on any patient that is 18 years or older. And if they don't have insurance, they're going to pay for it. If they do have insurance and they're under 40, they'll have to pay for it as well. Does any Medicaid plan cover it? I don't believe so, but I'm not sure. Every Medicaid plan is different in every state, so you need to check. Is the dentist liable if a lesion in the posterior part of the tongue is undetected? Asking because everyone doesn't have a pharyngeal mirror. That's a question you need to ask an attorney. I would think not, as long as you have written on the chart that you did an oral cancer screening. Buy a pharyngeal mirror for $10. It makes a big difference. I know tobacco and alcohol can be some of the risk factors for oral cancer. What about Morriscation buccerum? I don't know what that is. I'm sorry, so I'm not going to answer that. I once found a grainy granular texture on palpating the cheeks. Is that normal? No, it is not normal. It's something that should be investigated further. Something like that, have the patient come back in 2 weeks later, see if it's still there. If it's still there, it's something worth investigating. Thank you so much. That was great. Well, thank you for listening. Do I recommend HPV vaccines to your patient? That is out of my area of expertise. I talk about it, but I can't recommend it. I'm not a physician, and I don't believe in New York State I could give HPV vaccines. I might be wrong, but that's not something I want to get involved with. But I would certainly have a discussion with the patient about it. Wonderful topic. Thank you. You're quite welcome. How many malignant lesions do I see on average a year? Honestly, one every 18 months, probably, give or take. Is there a better fluorescent visualization device? Currently use Velscope. Velscope is a wonderful device. If you're not getting good results, I would call the Velscope people and make sure you get trained better with it. Or email me and I'll get you the training that you deserve from the device. Goggles are good. Velscope is good. They're all good as long as you know how to use them. That's the important thing. If you don't know how to use them, they're useless. What device do you recommend? Doesn't matter what I recommend. I recommend a device that's going to show you how to use it, that's going to train you on how to use it. Plain and simple. Every dentist does things differently, so I would use whatever I can get trained well on. Are RDAs qualified to perform oral cancer screenings? I do not know. That is something that is written into the Dental Practice Act of every state. So that's something I would check with my boss and have him check the Dental Practice Act of the state. Every state's going to be different. What's my opinion on the adjunctive oral cancer screening tool, Oral ID? Oral ID is a fine device. The problem with Oral ID is that you used to be able to buy it, $1,500 and you were done. And then they changed their tune and said, you can't buy it. You only have to rent it. and it's $150 a month forever and ever and ever. And from a return on investment standpoint, that doesn't make any sense. I don't know if you can buy it now or they still do the $150 a month, but $150 a month for as long as you have it just seems to be a little excessive to me. How would you handle a patient who wants a lesion removed but declines sending it for biopsy? Legally, any tissue removed from the mouth by law must be sent for a biopsy. So if he wants the lesion removed, you tell him it has to be sent in for a biopsy. That's the law, that's the rules. So you either have it sent for a biopsy or not. The biopsy, 99.999% of the time, the reading of the biopsy by the pathologist is covered by medical insurance. So not anything to worry about unless, of course, they're uninsured. D0431, yes, that's the correct code, D0431. Is it safe to refer to oral and maxillofacial surgeons the excisional biopsy and do only incisional in the dental clinic? Yeah, whatever you feel comfortable with. If you feel comfortable just doing incisional, then just do incisional. And it looks like my time is up. If you have other questions, please email me, laserbobdds@gmail.com, and thanks for listening.